Okay, I'm recording now the webinar. So good afternoon, everybody. Thank you for joining. My name is Anja Hermans, and I work at the Institute for Medical Genetics at the University Tübingen in Germany. I am a training manager for the European Reference Network for Rare Neurological Diseases. And I'm very glad to welcome you to today's webinar, which is part of our joint webinar series, which we have organized together with the European Reference Network for Rare Neuromuscular Diseases and with the European Academy of Neurology. So I will give you some information, general information about today's webinar. Let me just share my screen. Okay. So the topic of today's webinar is immune-mediated choreas and will be presented by Jan Lewerenz from the University Hospital Ulm in Germany. These webinars are on rare neurological, neuromuscular, and movement disorders. And we have normally a presentation of 30 to 35 minutes with a subsequent Q&A session around 15 minutes at the end. So please write your questions in the Q&A section, which you can find in the lower toolbar on the left side. And if you have some general questions, you can write them in the chat box and I will try to answer them during the webinar. So the target audience of the webinar includes neurologists, residents, pediatric neurologists, geneticists, and other personnel that is involved in patient care as nurses or physiotherapists, for example. And we announce our webinars all over, not only in the R&D member hospitals, but also in the affiliated partner hospitals and also non-R&D hospitals across Europe and worldwide. So as I said at the beginning, this webinar is recorded and will be published on our website. Here you can find the link at the latest 2 weeks afterwards. And you can also find further useful information on this website. At the end, your browser will automatically open a window with a post-webinar survey, which should take only 2 to 3 minutes. So it will be great if you can just fill this survey because it helps us to improve the webinars and hear your feedback. And also you can enter some topic ideas for the next webinars. So I hope you can hear me all well. You're muted in order that we have the best acoustic experience, and please write your questions and remarks in the chat box. So I would like now to present our today's speaker, Jan Lewerenz, who is since 2011 a senior attending neurologist at the Department of Neurology at the University Hospital Ulm. And since 2018, he is co-head of the Huntington's disease outpatient clinic. And since 2015, he's co-head of the cerebrospinal fluid laboratory with special expertise in antineuronal and onconeuronal antibodies. He's also head of the outpatient clinic for autoimmune encephalitis and paraneoplastic neurological disorders since 2014. He has also other positions as, for example, he is in the extended executive board of the German Association for Cerebrospinal Fluid Diagnostics. And he's also in the scientific advisory board of GENERATE, which is abbreviation for the German Network for Research of Autoimmune Encephalitis. So a little bit information on his professional background. He has finished his medical school at the Hamburg-Eppendorf University, Germany, and has has stayed there for his postgraduate education at the Center for Molecular Neurobiology. He has conducted his doctoral thesis at the Department of Neurology at the University of Hamburg, and has been a postdoctoral research associate at the Salk Institute for Biological Studies in California. For his neurology residency, he has been at the Department of Neurology at the University Hospital Hamburg, and has obtained his lecture certification or habilitation in neurology at the Ulm University. So I'm very glad that we have today Jan Lewerenz speaking on immune-mediated choreas. Thank you for accepting the invitation, and please, you can start with your presentation.
So first of all, thank you very much, Sanja, for this nice introduction. And I have to thank everybody who's organizing these webinars for the opportunity to give a talk about this interesting subject. So within the next 40 minutes, I will try to cover certain subjects. First of all, classical choreas, which are immune-mediated, like Sydenham's chorea or chorea associated with antiphospholipid syndromes, but also autoimmune choreas with specific antineuronal antibodies, paraneoplastic ones, and those with antibodies against neuronal surface antigens. Okay, so I can move my presentation. So that's what should I do? Oh, what is here? Okay. Okay. So by the end of this webinar, you will be able to identify red flags potentially treatable choretic movement disorders of autoimmune origin. You might be able to choose appropriate diagnostic tests to verify or exclude specific subtypes of immune-mediated chorea and state important therapeutic approaches. So first, I would like to ask you what the best description of your profession is, as this is not a genetic subject. I missed the geneticist, but I hope you can vote for G if you are a geneticist. I'm sorry.
Okay, so I will blend in the question. You have 45 seconds to answer this question, and then we will show the results. Okay, so here are the results.
Okay, so this is what I thought. So most of you are movement disorders specialists, and there are hardly any immunology specialists. So it might be something that is actually a topic that you normally do not cover during your normal days. So first of all, I want to introduce the Sydenham chorea. So this has been actually described many years ago in 1686 by Thomas Sydenham, and he realized that after a throat infection, some people get choreactic. So this is a post-infectious disease. All of you might know that it is the result of an infection with group A beta hemolytic streptococcus, and it's an immune-mediated striatal pathways dysfunction and as part of rheumatic fever. So as it's a part of rheumatic fever, increased antistreptolysin O titers or anti-DNase B titers, especially when they rise during the time of observation, are diagnostic, or a positive throat culture for group A beta hemolytic streptococci. There are also tests where you look for streptococcal carbohydrates, but this only works when there is a high probability of a streptococcal pharyngitis in the child. As I told you, Sydenham's chorea normally does not occur alone, but in the complex of rheumatic fever. And in 2015, the diagnostic criteria for rheumatic fever have been updated. So there are different main criteria. First of all, there should be evidence of a preceding group A streptococcal infection, plus major criteria which include carditis, arthritis. Chorea is also a major criterion. Erythema marginatum, which is shown here in this picture, which is rather rare, but very specific. And some patients develop subcutaneous nodules. There are also minor criteria, which are only arthralgias, fever, an increased C-reactive protein, or erythrocyte sedimentation rate, or signs of a heart dysfunction in as a PR interval that is increased. To diagnose rheumatic fever, you need two major or one major criterion and a minor criterion. So how often do patients with rheumatic fever get chorea? Well, the annual incidence of rheumatic fever is actually higher than expected, I think, at least in this survey in Northern Italy. It's 3.2 to almost 10 per 100,000 5 to 14-year-old children. And the relative frequency of the major criteria for acute rheumatic fever, carditis is the most often, followed by arthritis. And then there is the chorea, which is 10 to 30% of these patients with a female predominance. So all the other symptoms are much more rare. Yeah. So here is a paper from a table from a paper from Brazil, where it shows that actually the number of female patients are a bit higher in choretic patients, but on the other hand, only 30% of patients with Sydenham chorea do have neither carditis or arthritis. So there are patients that only have chorea without any other major symptoms. Patients present with hyperkinetic syndrome, which includes dysarthria, but also hypotonia and motor impersistence. Hung-up reflexes are thought to be specific for Huntington's disease, but they also occur in about a third in these children, and also hypometric saccades. As you may all know, Sydenham's chorea is also associated with neuropsychiatric symptoms, major depressive disorders, but also tic disorders and attention deficit hyperactivity disorders are much more frequent in patients with Sydenham chorea than those with acute rheumatic fever alone or healthy children. Imaging studies in Sydenham's chorea actually look like this. At the first sight, it might look quite fine, but if you look at the basal ganglia, you see that they are kind of hyperintense and swollen looking. This can be more intense, like in this MRI. And the rare occasions where in a child a PET-CT is done, you see a dramatic hyperactivity, so of FDG uptake in the basal ganglia. Now, this is a typical
Segment 1 shows a boy with
clinical
asymmetric
presentation from the paper from Brazil
chorea with prominent facial involvement.
And what you see is that the chorea is distally pronounced, but also involving proximal muscles in the arm, and it's definitely asymmetrical with increased hyper activity in the left side. Okay, so the treatment is quite simple. You should eradicate the streptococci, but also have to prevent reinfections by long-term penicillin treatment, but also steroids and non-steroidal antiphlogistics are applied. The interesting thing I saw, because I'm not a pediatrician, that valproic acid, carbamazepine, and neuroleptics. Now, neuroleptics is clear, but valproic acid and carbamazepine are mostly applied in the trials. There is actually one trial which looked at the efficacy of steroid treatment in this disorder, and as you can see here, 2 milligrams prednisone of 4 weeks after the start of the chorea significantly increases the reduction of chorea within time. Normally the chorea lasts a couple of months, here up to 12 weeks. The outcome is relatively good. I thought that only 10% have residual impairment. The pathophysiology of this disorder is still not really unknown. There have been multiple papers showing that there is cross-reactivity between basal ganglia antigens and antigens or surface proteins or peptoglycans from streptococci. And there have been different antigens, proposed gangliosides or dopamine receptors, but until now, there is no specific marker or no specific antibody that can be tested. So the basic ganglia antibodies in Sydenham chorea are at least now a road to nowhere. There is no specific test, at least in the routine laboratory available. The other type of classical chorea associated with an immune origin is lupus erythematodes and antiphospholipid syndrome associated chorea. And actually this was described about 300 years, or almost exactly 300 years later than the other type of chorea by Escherson, who detected antiphospholipid antibodies. It was later described not only in systemic lupus erythematodes, but also in primary antiphospholipid syndrome, so a disease where you can only find these antiphospholipid syndromes without any diagnostic criteria for lupus. It is thought that about 5% or less of patients with systemic lupus erythematodes develop chorea, which is quite a bit, and about 70% of patients with this type of chorea have lupus or lupus-like disease, which does not meet all the diagnostic criteria mandatory to diagnose lupus, and about 30% have a primary APS, so only the phospholipid antibodies available. This is a disease that almost exclusively affects female patients, and it's not children like in Sydenham's chorea, but it's mainly affects young adults. The accompanying clinical manifestations are typical for the underlying immune disease. So several other manifestations of antiphospholipid syndrome, like ischemic stroke in 1/4 of the patients or deep vein thrombosis. And miscarriages are typical in women suffering from antiphospholipid syndrome, but all peripheral artery occlusions can also occur. Myocardial infarction is a rare complication, and other patients have manifestations of the systemic lupus erythematodes like polyarthritis or arthralgias, nephritis, serositis like pericarditis or pleuritis, valve lesions, which can also occur in primary antiphospholipid syndrome, and there is migraine much more often in these patients than in the general population. And as there's also neuropsychiatric lupus, about 5% of the patients have an accompanying psychosis. The laboratory finding to diagnose this disease are basically the antibodies that you can test to determine whether somebody has antiphospholipid syndrome, like lupus anticoagulants, like as a activity assay, or detection of anticardiolipin or beta-glycoprotein antibodies, which have to be repeated within several months and stay upregulated, because during infections there can be transient upregulations of these antibodies in people who do not have this disease. lupus erythematodes is associated with double-strand antinuclear DNA antibodies or antinuclear antibodies, and some patients have thrombocytopenia and hemolytic anemia. The MRI is normal in about a bit less than half of the patients. The others show subcortical or basal ganglia post-ischemic lesions compatible with some kind of microangiopathy or vasculitis. And the rare occasions where PET has been performed, as in the Sydenham chorea, shows a increased glucose uptake in the basal ganglia, especially in the contralateral side when the chorea is asymmetric. The clinical cause is so that mostly the chorea is the first presentation of an antiphospholipid syndrome if it's occur, and the chorea is episodic. Mostly there's only one episode, but in up to 30% there is more than one episode, and the chorea is typically exacerbated by oral contraceptives or pregnancy. It's a hemichorea in about 50% of the patients, and about 25% have other neurological abnormalities that are caused by additional ischemic lesions. It is responsive to steroids, but also symptomatically to neuroleptics. The mechanism actually is unknown. So here comes the first question. Yeah? So are brain-specific antibodies found in Sydenham's chorea essential for the diagnosis of both diseases? Sorry, I deleted the antiphospholipid syndrome. I have to excuse for that. Have been reproducibly shown to target gangliosides, have been published to bind diverse brain-specific targets, however not resulting in a specific routine diagnostic tests, and lead to irreversible basal ganglia damage. So which answer is wrong?
So you have 1 minute to answer here this question.
Oh, sorry. Which answer is right is
Yes.
the right answer. Pardon. I beg your pardon.
10 seconds left, and then I will show the results. Okay.
Okay. Yes. Wonderful.
Jan, we have also, maybe you would like to comment on that question, but we also have a question in the Q&A section.
Okay.
Maybe it is better also to address it now and not at the end.
Okay.
Yeah? Okay, so I will show that question.
Mm-hmm.
Question from Eba Lohman. Why do you give long-term penicillin treatment to prevent relapses only until age of 21?
Okay. The answer is that usually Streptococcus pharyngitis is a disease of adolescence or childhood, as far as my understanding is. So after that, you actually won't get these infections as frequently anymore. So this is at least my understanding, although I'm not an infectiologist.
Okay.
Okay.
So I can close that and you can go ahead with the presentation.
Then I close this here. Okay. Okay, so as I said, the next part will be about autoimmune choreas associated with specific antineuronal antibodies, and to explain what type of antibodies actually are tested in a routine diagnostic lab that have clinical importance. I have this little cartoon here which shows that there are actually antibodies against antigens that are intracellularly on the left side. For example, here anti-HU or anti-TR. So these actually are antigens that are not accessible to the antibodies, but they occur in diseases which are thought to be mainly T-cell mediated, and the antibodies are only a diagnostic tool to detect these diseases, but they do not have any pathophysiological importance. On the other hand, on the right side, there have been the increasing number of antibodies that are directed against antineuronal neuronal surface antigens have been detected that do not are not involved in mainly a cytotoxic response, but they modulate neuronal functions by either activate or inhibit or decrease the surface expression of some neurotransmitter receptors. In the middle, there are some exceptions, for example, the GAD antibodies, which are intracellular and might be accessible to antibodies, but this is not covered here because there is no type of chorea associated with these antibodies. So when we look at these intracellular antigens, these are mostly associated with paraneoplastic diseases, which means these are diseases that are associated with a tumor, and the tumor induces an immune response, which basically cross-reacts with the nervous system. And there have been a European network for paraneoplastic diseases that actually did a survey what kind of patients with chorea and paraneoplastic syndromes were included in this huge registry. And as you see, it's not a huge number. So this is quite rare. And if you look at the age, these are mostly elderly people in age 60 or more, and mostly male. And the underlying tumor was in most cases a small cell lung cancer, colon cancer in some instances, and non-small cell lung cancer in others. The antibodies detected, and I will come to this in detail in the next slides, are either anti-HU, which is also called anti-nuclear neuronal antibody 1, ANA1. It depends on the lab which has given it a name. And the other antibody that is found has also two names. This is CV2 or anti-CRMP5. So there are only two antibodies that are associated with paraneoplastic chorea. And this here on the left side, you see the most typical onconeuronal antibodies. That means when you find these antibodies, you can be sure of 95% sure that this patient has some type of cancer. And the antibody species that occurs more often is the anti-HU, which occurs in 40%. And this is either in children with neuroblastoma or in adults with small cell lung cancer. And it is found in paraneoplastic neurological syndromes that are quite diverse, from sensory neuropathy to limbic encephalitis or cerebellar degeneration. The other antibody, I told you, the CV2, is quite rare. Only 5% of these antibodies are this subspecies, and patients with small cell lung cancer or thymoma have these antibodies when they have a paraneoplastic disorder. And also this antibodies are associated with many different clinical presentations, from neuropathy to limbic encephalitis, but also, and this is rather specific, with paraneoplastic optic neuritis. So this is how it looks like on the left side. This is a tumor, in this case a dysgerminome, that expresses HUD, which is the antigen of this, the HU antibody. And normally this antigen is only expressed in the brain. This you see on the left side a slice of cerebellum and intestine, where you also see that intestinal nerve plexus express this antigen. On the other hand, this other antigen, the collapsine-related membrane protein 5 is expressed in oligodendrocytes and to a lesser degree in neurons. And so these antibodies are associated with different presentations with regard to the MRI. As you see here, most patients with CRMP5 antibodies or CB2 antibodies showed some kind of leukoencephalopathy upon MRI imaging, whereas very rare instances, there's also some hyperintensity of the basal ganglia seen in these patients. So for paraneoplastic disorders, immune therapy is mostly not really effective or highly effective. There are some exceptions, and tumor therapy to detect the tumor and treat the tumor is the best to stop the attack of the immune system. But in these cases, there was hardly any response to tumor therapy, and there are inflammatory cells, CSF changes in some patients, but not all, so which basically ensures that it is an inflammatory diseases. And when you look at the typical CSF findings in patients with paraneoplastic syndromes, you come to similar numbers, but the number of patients are much higher. This is also from this network publication about a bit less than 300 patients, where you can see that slightly less than the half of the patients have CSF pleocytosis, indicative of an inflammatory disease, and 2/3 are positive for oligoclonal bands restricted to the CSF, proving an immune-mediated disorder. But about 10% showed normal CSF results. So a normal CSF does not exclude a paraneoplastic disorder. The prognosis is rather grim, as you see here, that either many patients died from the tumor, or actually they died from the paraneoplastic disorder within several months. So how to get an idea whether this is a paraneoplastic disorder? So as I told you, there are many different syndromes, and as you see that here marked in this table, some of these patients also had other manifestations like polyneuropathy or limbic encephalitis. And so I come to the first movie, and this is something I think is really interesting. So, and just look what this person does. So she has problems to hold her hands still. Also the feet.
Legen Sie bitte die Arme mal wieder hin.
Okay. So we come to the next question. So you are movement disorder specialists, so most of you. What do you think that this patient most probably has? It's a classical chorea with slight lateralization to the left. Is it myoclonus? Is it a pseudoathetosis due to sensory deafferentiation? Or is it cerebellar ataxia? Okay. Okay, yes. So most of you voted for the right thing. So this patient has a Denny Brown syndrome. So she has a severe problem to know where her limbs are. So they're differentiated, and you classically see in these patients that they have problems to hold their hands still. But this is not a chorea in sensu stricto. So how do you manage patients with a paraneoplastic syndrome? First of all, these diseases are really rare. You have to search for an underlying neoplasm because this is the best thing to stop the attack of the immune system. So normally you should check your patients every 6 months up to 5 years for the underlying tumor. They can be quite small because actually they are suppressed by the immune system. Depending on the suspected tumor entity, and you know it because you know what the antibody is, and the certain antibodies are associated with different types of cancer, you might use an FDG PET or other things. So the tumor therapy is at the center of the management, and immunosuppression should be used as fast as possible because it's a cytotoxic T-cell disease. So every neuron that is dead won't come back. So methylprednisolone in high doses are normally used at the start, but usually you have to escalate the treatment, for example, to cyclophosphamide. In the PNS, also alternatives like intravenous immunoglobulins or plasma exchange can be tried. So how do you test for these onconeuronal antibodies? This is a cartoon of a microscopic slide with a tissue section on it, and the antigens are shown in red. And actually you incubate the serum with this tissue sections, and the specific IgG binds to the antigen, and then it gets detected by a fluorescence coupled antibodies. And when you look through a microscope, you see these patterns. These are all cerebellar sections, and as you see, the HU antibody has a kind of nuclear staining, but this is not an anti-nuclear antibody. It stains only the nuclei of neurons, but not of glia or other tissues. And the other antibodies have different patterns of immunofluorescence, but this has to be confirmed by another specific test, and usually kind of Western blot is performed where recombinant proteins are blotted to a nitrocellulose membrane, which then acts with the serum and gives a band which antibody is positive. However, not every paraneoplastic syndrome actually has onconeuronal antibodies. It's about 20% that lack these antibodies. So if the clinical presentation, which is normally subacute or relentlessly progressive, insinuates that there is a paraneoplastic origin, one has to look for a tumor. The last part of this seminar will be about choreas with autoimmune encephalitis associated with antibodies against neuronal surface proteins. And actually, these type of antibodies have just been detected recently, because the type of fixation for the brain section that was used was optimized to suddenly detect antibodies that bind against synapses, which occurred suddenly in this test in patients that were antibody negative beforehand. And within the last years, the number of these antibodies binding to different target antigens have increased considerably. So the first basically was the voltage-gated potassium channel complex antibody, which is nowadays obsolete, which was in 2004, and the first specific antibody was the antibody against the NMDA receptor. Quite a high number of these diseases are actually reportedly associated with chorea, so the NMDA receptor, the LGA1 and CASPA2 receptor, but also GABA-A receptor, ICLIN-5 and norexine A antibodies. But however, at least in my opinion, the GABA-A receptor and the norexine A 3A antibody are very rare, and these are normally highly active severe encephalitis cases where chorea and dyskinesia are associated with this really severe disease with reduced consciousness. So there is hardly anybody comes to your outpatients clinic as a movement disorder specialist. These patients are in an intermediate or intensive care ward. This is also true for patients who have an encephalitis with NMDA receptors. However, this disease is rather common, but also here, with some exceptions in children, the chorea and dyskinesias are associated with a severe encephalitis. So there is no possibility that these patients might have Huntington's, chorea, or other diseases. As it's so common, I will shortly describe this disease. So this is a disease that normally occurs in younger people. It is thought that about 1% of all patients in neurological intensive care wards suffer from this disease, and almost 4% of all cases with encephalitis are encephalitis with NMDA receptors. About half of the patients have a tumor, which is normally an ovary teratoma, and most of the patients are female. And this is the typical movement disorders in severe, oh, this is an odd sound, NMDA receptor encephalitis. But as you see, these patients have a reduced consciousness, and are on an intensive care ward. Okay. The patients encephalitis with LGR1 antibodies is rather common, and both diseases which have antibodies against antigens that complex with voltage-gated potassium channels can have a protective cause and have a prominent chorea that is possibly confused with neurodegenerative diseases, at least in some cases that I also know. So this is quite important. And so, as I told you, in earlier days, it was thought that these antibodies are directed against voltage-gated potassium channels, but now we know that they are actually directed against antigens, so transmembrane or membrane proteins that are in complex with this voltage-gated potassium channel. There is a large variety of different clinical presentations, which at the first sight are quite confusing. So Caspar-2 antibodies can be associated with peripheral hyperexcitability, for example, neuromyotonia, Krampus fasciculation syndrome, but also in some cases with isolated limbic encephalitis, whereas LGR1 antibodies are mostly associated with limbic encephalitis, which typically in 2/3 has a hyponatremia as sometimes a diagnostic sign. Some patients have an overlap with both, and those might have myotonia, encephalopathy, and this is diagnostic, insomnia. There are also signs of peripheral sensory hyperexcitability like hyperhidrosis and neuropathic pain, and these diseases normally respond rather well to immunosuppression with steroids, intravenous immunoglobulins, and plasmapheresis. The patients that have these antibodies are mostly elderly males. Here you see systematic review of many patients that have had cerebral spinal fluid findings present. So the age median is about 60 or 70 for both diseases, and females are only 1/5 to 1/3 in these patients. There are actually cases published where patients with LGR1 antibodies have hyperintense basal ganglia, but these patients do not necessarily also have chorea. Typically, at least in this publication, they have a specific type of seizure, which is called faciobrachial dystonic seizure. This you can see here, which sometimes occurs way beyond the other symptoms of limbic encephalitis, like confusion, seizures, memory dysfunction, and neuropsychiatric symptoms. There are rare cases of autoimmune chorea with LGR1 antibodies, which are isolated and not associated with other symptoms of limbic encephalitis, like this patient here.
Close your eyes. Now, can you
It is
say the months of the
relatively
year
mild, I have
backwards,
to
starting
admit.
with December?
But a recent survey about a large number of patients with LGL1 disease, these were 38, did not detect any patients with chorea, so actually this is quite rare. In Caspr2 antibodies, you also might have chorea. There are isolated cases described. Here is one from our hospital.
Das noch im Betrieb. Ich vermute das war noch im Betrieb vor Ultimo Jahren, hat das angefangen. Dann war natürlich die Nervosität, wo meine Frau ein Kind freigesetzt hat.
So, and here,
100 weniger 793. 90 weniger 7.
oh, this is rather anticipated. Sorry. But the diagnostic clue in this patient was that he also has a Krampus fasciculation syndrome. Electrophysiologically, it was not enough for neuromyotonia. But if you see a patient with chorea with fasciculation, it might be associated with Caspr2 antibody.
Jetzt ganz ruhig bleiben.
The last antibody that might be associated with chorea is the ICON-5 antibody. Actually, this is a disease that was just described in 2014, which is basically is parasomnia that was not considered to be of autoimmune origin beforehand. And pathologically, this is described by, characterized by tau aggregations in the brainstem. Nobody knows how this antibody is related to these tau aggregations. But in early cases, when you treat very early, it's kind of response to immune therapy. And a recent survey showed with 21 patients showed that about half of these patients, or a third of these patients, actually present with chorea, in addition to other symptoms, which can be the sleep disorder. Some have a bulbar syndrome. Some actually have a PSP-like phenotype or only present with cognitive impairment. And this is one patient of the first publication who presented in our hospital. And she was thought to have some kind of neurodegenerative disease. So her disease was about 12 years until she was diagnosed. And you see that there's also a dystonic component. So management of these diseases is basically to treat them as early as possible with immune suppression, and early treatment is associated with a better prognosis. So there has been an expert opinion how to detect these patients before actually the antibodies, for the most typical ones, the antibody results are back from the lab, because even losing a couple of days might be protect the cause of this disease. Normally, plasmapheresis, corticosteroids, or immunoglobulins are used. So how do you detect these antibodies? They are either detected using, for example, these red brains, where you see that there's a synaptic staining when they are incubated with diluted serum or CSF. And as an additional test, cells transfected with these antigens are used that where the IgG binds to. Not all findings are specific, especially for the Caspr2 antibody. Quite frequently, non-specific findings with low titer antibodies are found, which are not associated with an encephalitic phenotype, which is probably unspecific. And the NMDA receptor antibodies, which is very important, has to be tested in CSF in addition to serum, because this is much more sensitive. You lose about 15% of the results if you only do it in serum. And this demonstrates why this is the case. These are transfected cells. On the left, you see serum, right is CSF. You see that the signal to noise ratio in the CSF is much better. The frequency of pathological CSF results is very different in these diseases. So in NMDA receptors, it's quite frequent that there is inflammatory CSF changes, whereas in LGA1 associated autoimmune encephalitis is exceedingly rare. Caspar-2 is kind of in between, and ICLON5 positive patients hardly have any positive OCV and sometimes have pleocytosis, but mostly only have increased protein. So the next question would be immune-mediated chorea with detection of brain-specific antibodies. Does it warrant immediate immunomodulatory therapy? It might it be associated with different types of tumors depending on the identified antibodies? Has it a poor prognosis? And can it be excluded by normal routine CSF findings?
Okay, so here is the live voting tool.
So the question was, which answer is wrong? Sorry.
Okay. So here are the results.
So maybe that's probably my fault, because I should have told you that the wrong answer was the one to be picked. So the wrong answer would be has a poor prognosis. I'm sorry for that, because actually most patients have surface antibodies, and those who have surface antibodies actually respond well to therapy, and in a huge proportion can basically lead a normal life after they had the disease is over. Okay, so I think, let's see, the next question is a bit more tricky. So which statement is correct? Chorea associated with ICLON5 and Caspar-2 antibodies might be associated with sleep disturbances. Fasciculations are mostly found in patients with Caspar-2 antibodies. Sorry, the question should be which statement is incorrect. I have to, sorry, I beg your pardon. Testing serum is sufficient to diagnose autoimmune encephalitis associated with NMDA antibodies, and positive Caspar-2 antibodies in serum can occur without association with an immune-mediated CNS disease. So the question is, which statement is incorrect?
Okay, 30 seconds left.
Okay, wonderful. Yes, so most of you chose the right answer. So not only that positive NMDA receptors in serum might be unspecific, and in case the CSF is negative, there are 15% of patients which only have NMDA receptor antibodies in their CSF. So this is a disease where the antibodies are synthesized intrathecally. So this is why you should test the CSF. Okay. So I will conclude that autoimmune chorea is often associated with other clinical or laboratory findings that hint to the correct diagnosis of the underlying disease. Rheumatological tests or CSF analysis, including antineuronal or onconeuronal antibodies, should be included in the workup of unexplained non-hereditary hereditary chorea, and immunotherapy in many, many cases is beneficial. So thank you very much. And I think we still have a bit of time for the questions and answers session. Sorry, it was a bit too long.
Okay, so there is one question here. Could you please explain or comment why IVIG or PLEX is not recommended for CNS paraneoplastic syndrome?
Okay, so actually the question is not really easy to answer, yeah, because usually you would assume that plasmapheresis or plasma exchange, immune absorption is active in diseases where you want to remove an antibody. In onconeurological, onconeuronal antibodies, it's actually a T-cell mediated disease, and the antibodies are only indicative that this kind of immune reaction is going on. So removing basically the signal of the disease won't change the disease course. The theory is that some paraneoplastic syndromes, including involving the peripheral nervous system, also involve some demyelating component, or that basically plasmapheresis might remove cytokines that activate the immune system. That is the theory. So, but there aren't actually any trials comparing plasmapheresis, immunoglobulins, and other immunotherapies. There was a trial years ago directed by Cesc Graus and others from Barcelona, who basically could show that immunotherapy in average didn't work at all. And what made actually some benefit was the treatment of the underlying cancer.
Okay, there is another question. How long do you give IVIG in NMDA autoimmune encephalitis?
Okay, this is an interesting question because actually it's done very differently depending on the centers. We here, at least at Ulm, assume that NMDA receptor encephalitis is a phasic disease, so it has a natural cause, and even if you don't treat it, it will go away after some time. It lasts months in part. So basically we only give IVIG for 5 days and then look what happens. Normally we do not repeat administration of IVIGs. And if then the patient does not become better, you have to escalate for other things like rituximab or cyclophosphamide. And when this does not work, you can do some experimental therapies like bortezomib. But you basically do not give these patients a long-term therapy because in case they recover, they have a rather low chance for a relapse. you can do this. Some people do that they actually give the patients for a year or so oral immunosuppressants, but it's normally, I think, not necessary.
Okay, are there any more questions? If not, then we can finish our webinar here. And I would like to thank you everybody for joining and attending the webinar, as well as to Jan Lewerenz for giving this presentation. And the next webinar will be on introduction into leukodystrophies next week, same time and same place. Thank you everybody, and have a nice evening.
Thank you.
Bye bye.